Welcome to the Female Reproductive System lecture. In this chapter, we're going to take a look at the female anatomy. That's part of the reproductive system. And we will also look at gestation. So we'll go through that a little bit as well. And we'll hit some of the main topics that we also hit in the male reproductive system. So let's go ahead and get started on this. This mid-sagittal section of the female reproductive system, it looks like there's so many things labeled, but just like in the male reproductive system, after we had discussed most of the anatomy, it helped us to understand how the physiology actually works. I will bring your attention right away to the idea that the urinary system in a female is completely separate from the reproductive system. That's quite different from the male that had shared structures. So if we look at this urinary bladder here, where my mouse is going over the urinary bladder and the urethra, these are completely separate. Yes, are they very close? Obviously in proximity, and sometimes it can be confusing for an individual when they may be experiencing some urinary discomfort. They may actually think it has something to do with the vagina or something to do with their reproductive organs and vice versa. So sometimes it's really almost impossible for the individual to isolate that. And this is why it's very important post-puberty, after puberty, that any sort of issues that are occurring in the genitalia, it really does warrant a pelvic exam, and it warrants a urinalysis as well as a pelvic exam where they're going to take a speculum. And this is an instrument that is inserted into the vaginal orifice meaning opening, and helps to open it up so that inspection can actually happen of this vaginal area, and looking at the cervix as well. Also, doing a pelvic exam would also require palpation and, sometimes sampling as well. So vaginal secretions may want to be cultured and sampled, as well as getting urinary samples to test and evaluate. Again, even though these two systems in females are completely separate, sometimes it can be difficult for a female to really understand what might be, what is going on. So it would take a practitioner and the laboratory to be able to definitively decide what is happening. But let's go ahead and look at some of the basic anatomy here. When we think about the female, we said the tissues that become the scrotal sac in a male would become the labial folds in a female. Labium, this is Latin, a Latin spelling for labia. Labia just means lips. So there are the minor inner ones and the major outer ones. Again, this is just Latin for minor labium and major labium. So either way that you would spell these is correct. The inner folds are hairless. The outer ones do have pubic hair. Again, these same tissues become the scrotal sac on a male. The clitoris is the sensory organ, and you can see it here where my mouse is going, this entire structure here. The sensory is almost all internal, except for the end of the clitoris, which is got foreskin over it. That foreskin is called prepuce, just like the foreskin of the male's glands is called prepuce. So this structure, the clitoris, is the analogous tissues that will become a penis in a male, depending on the SRY gene. If the Y chromosome is present, the SRY gene is active, we said, for a short window of time during embryonic development, and it would cause these same tissues to become the penis in a male. This is the pubic symphysis, this is actually spelled wrong on the slide, I see. But anyway, this is where the pubic regions of the two os coccyx meet. So you are seeing just that bone there. Again, the urinary bladder is here with the urethra. The urethral orifice, the opening of the urethra, is just superior to, if someone is in a position having a pelvic exam, it's just superior to the orifice for the vagina, and then this is the anal opening or orifice. So three orifices here versus in the male where there is the urethra and the anus. If we're looking at these structures that are part of the reproductive system, the uterus is a muscular sac that is going to allow for the growth of the embryo into a fetus. There are ovaries on each side, usually two, right and left ovaries. So you're seeing the right one here, a right ovary that is in this pelvic cavity. The ovaries are where the eggs are released from. As they're released, they move into a tubule that's called the uterine tube, but also commonly referred to as the fallopian tube. This is a hollow muscular tube that allows for this egg, which if it's fertilized, to move through this uterine tube and move back into the uterus, which would then implant if there's a pregnancy. We also know that this uterus, it has a part of it is actually extending into the vaginal canal, and this is the neck of the uterus, so it is called the cervix. Cervical means neck, doesn't it? But the cervix of the uterus extends into this posterior fornix area of the vagina. The vagina is also sometimes referred to as the birth canal because it is not only after puberty designed to receive semen, but it is a muscular tube that also allows for the passage of the fetus during the birthing process. So, and I think you see this is the rectum. The rectum here, this is the last part of the intestines, the sigmoid, the rectum, and then the anus here. So something else I would maybe mention is on the females, there is this mons pubis area, which is a padding of fat over this pubic symphysis of the pelvic bone. So I think we've talked about most of these structures now. Rugae is actually how the tubule will actually have folds so that it can distend. So this is a muscular tube that allows for distension, as I said, for receiving of the semen, intercourse and receiving of semen, but also, importantly, to allow for the passage of the fetus during the birthing process. You've seen this term rugae before in the urinary bladder. These folds that you're seeing in the urinary bladder when it's empty are referred to as rugae. Okay, so we will, another term that you may sometimes hear about when a pelvic exam, it's not written on here, but when a pelvic exam is happening, they will refer to the external os and the internal os of the uterus, and that is referring to this opening at the cervix, the opening to the uterus here. So, okay, so again, a couple of these slides are redundant, they're repeat from the male, but we did talk about the idea that you really can't tell the difference much between a male and a female early on in embryonic development. But if it is a male, the SRY gene is on that Y chromosome and would be active, and then the organism would develop into a male. In the absence of that gene, there would not be that testosterone and MIH factor. So that means that the tissues then end up becoming what we associate with females. So really females, we are actually female by default, if you will, because it's the absence of those hormones that allow for that. The ovaries are the primary sex organs for a female. These are the female gonads. These are where eggs are actually produced. And another major difference between males and females is that females at birth will have all of the primordial eggs that they will ever have inside of these follicles. So that is a very big difference. And so what that would mean is that anything that's happening to that female, even during later gestation or early on, even before puberty, could potentially affect their eggs, their follicles. So males don't start producing sperm until puberty. And so anything that would happen, let's say that a young child had cancer and had to undergo chemotherapy and/or radiation, they know in the females that that could potentially, depending on what type of chemotherapy and depending on where the radiation needed to be administered, that could potentially affect future fertility for that female. Where in males, young males, that is not the case. So this is the anatomy of an ovary, and what we understand is that there are several 100,000 primordial eggs, follicles that a female is born with. In females, it is not about the quantity, it is about the quality. Certainly it is also about the quality of sperm as well, but even more so if you think about it when there's so many fewer of these eggs for females. By the late 30s, a great number of these follicles are no longer viable. And if you think about it, though, with females with a 28-day cycle, usually there's just one follicle that's targeted. So each year, each 28-day cycle, so each year you're looking at maybe 12, 13, 14 follicles that would have to be productive. And then if you think about a 30, even sometimes longer than that, depending on the individual, 30 plus years, maybe 40 even, for fertility for a female. It all depends on the woman, the female. Some are much less than that as far as years fertility go, but there are really not that many eggs that are used. So again, it's more about the quality than the quantity for a female. When we think about the secondary sex organs, we certainly know the duct system has to be, the integrity has to be there. The uterine tubes must be hollow, remaining clear and healthy. The uterus must be healthy and the vagina as well. So sometimes repeated infections or repeated, heaven forbid, injuries or circumstances that could cause scarring of this duct system could eventually, potentially adversely affect fertility. The external genitalia is the clitoris, the labia, and this occupies an area we call the perineum. There's also important accessory glands that allow for lubrication of this particular site. So when we think about the uterine or fallopian tubes, also called the oviducts, you can see a picture here. I think this next slide might be better, where you're seeing a coronal section. So the front has been dissected. It hasn't been dissected here, but the front's been dissected so that we can see inside this hollow tube that is the fallopian tube or oviduct or uterine tube. Again, the ovaries are sitting here nestled in the pelvic cavity. This is the left one, this is the right one. A coronal section's been made here. So as ovulation occurs and an egg is released, it is going to be encouraged to go into this tube. These little finger-like projections that you see here are called fimbriae, and they are gently encouraging, moving this egg into the outermost part of the uterine tube. This is typically right in this area where fertilization typically occurs, right here. So sperm has been deposited into the vagina, which is where my mouse is right now. Sperm has been deposited here, and the sperm has had to move up through the opening in the cervix, the part of the uterus that extends into this fornix area of the vagina, the birth canal. So sperm have to move through this cervix, through the uterus, and move into the uterine tubes, the fallopian tubes, and sperm have to swim all the way out to here. Now, of course, some of them, each month, one ovary is targeted. So some of the sperm will end up going the wrong direction and they will never make it, obviously. But it only takes one sperm for the egg. So if one gets to that egg, and fertilizes that egg, that process is when the gametes meet and fuse, and the new cell that's formed is called a zygote, which I know you all remember the name of that. And now this zygote is going to move into the uterine tube, if it's not there already, and start the process of moving back toward the uterus. This usually takes about 6 days for that to occur, for the fertilized egg to get back to the uterus. And then a very important thing has to happen. It has to implant. It's thought as many as a fourth of all fertilized eggs never implant and are just lost. When I say lost, I mean they just didn't implant. So, some people feel like life sort of begins. All these cells are alive. All of our cells are alive. Our skin cells are alive. Our cells are alive. But some people think of life as beginning at fertilization. But again, a full fourth of these, it is estimated that's probably a low number, just don't implant and are, just involute and are reabsorbed. The tissues are just the cells are reabsorbed. It's by the time it gets here, the cells have been dividing. The zygote has been dividing, and those group of cells are in a little fluid-filled sac called a blastocyst sac, and they have been dividing the entire time. And by the time they get to the uterus, there's enough of them that they, if they implant, there's going to be a chance that pregnancy will be sustained. And we'll talk more about sustaining pregnancies in a little bit, but this is how that process kind of happens. Okay. And again, I just mentioned that sometimes on pelvic exams you'll hear about the internal and the external os of the cervical canal. And again, there is this fundus area that y'all have seen that term before with the stomach, the upper regions of the stomach, this fundus area, which would allow for as the uterus starts to expand, if there's a gestation actually happening. Again, a muscular, incredibly muscular organ that allows for gestation and then also the birthing process. When we think about the uterus, we think about the different layers, the histological layers of the uterus. The perimetrium is that external layer. Myo means muscle, is that middle muscular layer, which is pretty impressive. And the endometrium, which are that inner layer. So again, if you think about the perimetrium, the myometrium, and the endometrium on the inner layer. This endometrium is the layer that is going to be enhanced during a monthly cycle to get prepared to accept blastocyst as it's moving through the uterus. This, if that doesn't happen, if pregnancy doesn't happen that month, this is what is shed with each menstrual cycle. So this is that outermost layer that is shed. When people think about, and I think this is a good picture to look at here, when people think about menstrual flow, I think sometimes they think this is like blood from the peripheral veins. It is not. It looks like that essentially, but it's actually tissue that has been cultivated throughout the earlier part of the monthly cycle. So it's really enhancing the tissues here. They actually thicken. They get to their thickest part when an egg might be fertilized and now a blastocyst and going to arrive in the uterus. And if that doesn't happen, then that outer endometrium will be shed. Again, it kind of looks like peripheral blood, but it is not. It is the endometrium, the stratum functionalis. Now, the uterus itself is an organ, so lots of blood supply. And the reason that, and it needs blood supply, but the reason the stratum functionalis is actually shed if there's no pregnancy is because the uterus needs to get in shape for the next month in case pregnancy is going to happen the next month. So what will happen with these little arteries is that these spiral arteries is they start to contract if no pregnancy happens. And as they start to contract, they cut off blood supply to this outermost layer. And that's what you see in menstrual flow. If someone is actually losing peripheral blood during a menstrual cycle, that is not normal. So, that would not be considered really a normal thing. So if somebody is anemic or their hematocrit is lowering, and y'all all know what those terms mean, then, and they think it's because of heavy flow cycles, that is not a normal situation. Some women have heavy flow cycles, but it's still only the stratum functionalis, and it's because they were very well cultivated during the first part of the menstrual cycle, the 28 days. They were getting ready for that, and so they may have a heavier flow than most. So the vagina, now we'll take a look at the vagina, or what is also called the birth canal. This is a muscular tube, so it's distensible, so it allows for the receiving of the penis, and an erect penis. It allows for that, and also the depositing of semen. But then it also allows for this distensible muscular tube, the movement of a fetus through that birth canal. So this, we can look at how it is, just the positioning of this when you go back to the mid-sagittal section, but you can see the positioning of this. These tissues before, in children, before puberty, are simple one-layer cuboidal. They're not protective. They're not designed for anything to be in the vagina at all. But after puberty, with the estrogens that are going to start to go up and down during a monthly cycle, this is going to change those tissues. We call this metaplasia in a normal situation. Usually we don't think of that term as being a term that we want to hear, but this is a natural situation. With the estrogens at puberty, the onset of puberty, the lining of the vagina turns into stratified squamous, so it becomes absolutely designed for the receiving of semen and a birth canal. The bacteria also change, and then the normal bacterial flora that are there are protective for the female, because if something if the female gets introduced to a potential pathogen, it has to be of a particular amount, or their vaginal secretions will be very protective. Vaginal secretions are normal, they are natural, they change throughout a monthly cycle depending on how the hormones are changing through a 28-day cycle, but they're absolutely cleansing, and nothing should be really introduced into the vagina. I know that some people still, well, no medical people believe douching is a good thing. It's really a horrible thing for a woman's health. That does not need to take place. It is very detrimental to a female's health of these tissues, because the natural secretions from the vagina are cleansing. And again, the bacteria that are there need to be in a particular balance, or it can set the woman up for micro tears, and it can also set the woman up for infections that if that hadn't happened, then she would have been able to protect herself. So the vulva is actually this area, this external area that we think of that includes that mons, the padding of fat over the pubic regions of the os coxae, and the labia and the clitoris, and these erectile tissues and secreting glands that keep this area moist. So when we're looking at a perineum showing this particular region, this is what we're seeing. So again, the urethral orifice is just superior to, above, the vaginal orifice, and the vaginal orifice is superior to the anus. So this is what you're looking for. The inner hairless folds are the labia minor, or labium minus, Latin. Labium majus is actually the major labium, is the outermost folds with hair. Again, there are glands here. I'll show you these glands, the greater vestibular glands that you can see, and they're going to, and the periurethral glands, keep this area cleansed, moistened, and protected so that there's not drying out. Drying can cause micro tears, which can again put the female at risk for infections. So these glands need to be functioning as they should. Again, you can see the pubic region of the os coxae here. and this is the pubic syphysis we were talking about. The glands of the clitoris is what is external, and then you also have the prepuce, which is that some people call that the clitoral hood. You know, you hear about that being pierced sometimes, whatever. This is actually a good picture to show you of the deeper structures that are in this perineum area. The anal sphincter, this is that round muscle that, you know, is under voluntary control around the age of 2 for defecating. But you can see some of the muscles here, and you can see these important glands. One of the reasons I want to show this to you too is you may not have heard of this, but it's called an episiotomy. An episiotomy is during childbirth. They will, the later stages of childbirth when crowning is happening. This isn't done as much anymore, but sometimes it's still being done, where they will take a blade. They don't even have to numb because the whole area is numb because of the pressure of the head. In childbirth, the pain is actually from the uterus, and even though there may feel like a ring of fire, this is called, during natural birth, they don't need to numb it when they do this, but they will take a blade and actually cut here and down to the side of the anus to control some of the tearing that might happen. Not all women tear during delivery. It all absolutely depends on the head size of the fetus, and also the pelvic outlet of the female, but it's usually the head size. It doesn't even have to do with the weight of the fetus. It's the head size of the fetus in relationship to the pelvic outlet. But if there is difficulty in delivering that head, if there's any sort of concern that there may be a long, prolonged labor part, which is the pushing part of delivery, that then sometimes episiotomies are done. The reason they do that is to control what kind of the tearing, because tearing can be kind of jagged. The reason to not do an episiotomy, and why most people are getting away from that, is because tearing is natural, and the only thing that would tear would be the superficial skin. None of these glands or muscles would be injured at all. So even if there was a lot of tearing, and they do it by degrees, they evaluate it by degrees, it could still be repaired. Where if the blade, which you kind of don't have control, you may not have as much control over, especially when head is crowning, and with the blade, it may be that accessory structures like some of these that you are seeing could be actually injured, and then that would make the healing process a lot more difficult. And also the blade, you know, you don't know where the blade might be going as far as blood supply, nerve supply, muscles, glands, where tearing would be absolutely natural, and it would only happen to the outermost tissues, the epithelial. So maybe that, hopefully that makes sense to you as I explain that. The breast are going to, I think everybody knows where breasts are. If you didn't, here is a lateral view of seeing the breast. But obviously the breasts are going to play a huge role in the production of milk. This is where the mammary glands are found. So I will go to this so you can see. Breast tissue, unless someone is lactating, pregnant or lactating, is almost all fat. The mammary tissues are going to be enhanced during a pregnancy because of prolactin and the hormones of pregnancy. So these mammary glands will start to develop, and they will, this is why some women, the first sign that they know they're pregnant may be because of the sensitivity or the change in their breast tissue. That may be one of the first signs that they actually feel. The areola is the colored area of the nipple. The nipple itself is here. As you can see, the areola is that colored area. So again, non-lactating contains little glandular tissue, and it's just fat tissue and a series of ducts here. You can see that the breast is over the pectoralis major, which you all know where that is. And so that's just a little bit of the anatomy there. Again, you've got the areola and the nipple and all of this mammary gland ductwork coming to the nipple. Breast cancer in women, it's still, the numbers still look to be about 1 in 8 American women. This varies in different groups, like Black women versus, I don't usually say that because I think, there's one race really, but there are different ethnic and cultural hereditary predispositions for that. So we know that, and darker tone women, Black women, have a higher incidence of breast cancer, but on average it's about 1 in 8 American women. And then there's no such thing as one type of breast cancer. There are different types of breast cancer. So once breast cancer has been diagnosed, then they're going to have to type it to see how to go about figuring out exactly how to treat it. So when we think about risk factors, we know that aging, exposure to radiation, carcinogenic chemicals like smoking is a factor. Alcohol and even fat intake can increase a chance for breast cancer. But as we see, a lot are also non-inherited, and there really isn't any sort of risk factors. I personally have known some people who had breast cancer who had none of the risk factors that we tend to think about. So all women at puberty all females at puberty, hopefully, are getting taught to do breast examinations in particular times of the month. They should do them at a particular time of the month each month, because your breasts do change during a 28-day, during an average cycle, whether it's 28, 32, 24 days. We'll talk about 28 days being the average. You should do it always at the same time, because your breasts do change during that monthly cycle due to the influence of the hormones during that cycle. So when women should start checking their breast at puberty and be very familiar with any particular changes that they note, whether the change is painful, like a painful nodule, or whether it is not. Any kind of change should be noted and then discussed with the health professional if the person feels like that it needs to be. So that would be important to do. At puberty, we call puberty, really, when we think about it, menarche is that first menstrual flow, but puberty, which we think of around age of 12, but it begins before then. It begins before then, and the FSH and LH that we have talked about, these gonadotropin releasing hormone from the hypothalamus, will tell the pituitary to release FSH, which we know is going to stimulate eggs, a follicle for an egg maturation, and luteinizing hormone, which is going to stimulate ovulation. We learned back in the endocrine system. We know there are going to be these once that starts, there's going to be these cyclic hormones that change throughout the 28-day cycle, or whatever your cycle might be. Thelarche is the development of breast. Pubarche is going to be the secondary sexual characteristics that we think about: pubic and axillary hair, the oil glands, the sweat glands, apocrine sweat glands that are going to be secreted as well. The change in the vagina that most people don't know is happening, but does happen. So getting the female ready for this first menarche, because with the first menarche, this actually is the female, that individual would be able to become pregnant at that time. So that is going to require a certain amount of health. So when we think about that, we think about a certain amount of percent body fat that's going to actually require. Climacteric and menopause is very different in a female than males. We said males have it as well, but males go through male menopause. But with females, when females go through the menopause, and the average age is around 52, some much younger than that, some older than that, the average is about 52, then a woman will stop producing eggs. Again, it's more about the quality and not the quantity. So with the stopping of the menstrual flow and the stopping of producing eggs, this is going to change the levels of estrogen and progesterone that are being secreted. And with that decrease in the secretion of these hormones, then other things will take place. The uterus is going to atrophy because it is no longer, there would no longer be a potential fetus for development. The vagina, the tissues of the vagina and the breast also change. So skin is affected, bone mass declines, and the risk of cardiovascular disease actually increase. Some women are very susceptible to the changes of menopause. They go through, they feel this perimenopausal types of symptoms that they feel, these hot flashes, they will feel mood swings, they will actually have sometimes heart palpitations, all of these things just prior to going through a complete menopause, and then sometimes even a little while afterwards it will happen. And if they are affected greatly, they may decide that they need some hormone replacement therapy, well, along with their physician. So in seeking help for this, if all of this has become something that, is intolerable to them, sometimes hormone replacement therapy will be administered. And that is usually a low dose of estrogen and progesterone therapy in combination. That's always given in combination because we know now that that is going to reduce some risk that this actually has, because hormone replacement therapy does hold risk. So it's usually a very low dose of that. This is kind of when we think about women who are on oral contraceptives during their reproductive years, those are also usually a very low dose of estrogen and progesterone as well. Okay, so the beginning of an egg and the sexual cycle, I do want to let you know, as far as an egg is made, the same type of cell division has to happen in the gonads of a female, the ovaries, that happened in the testes of the male. It is called meiosis. And meiosis is going to start with one cell that has 46 total chromosomes, but it will undergo two divisions, exactly like when we were talking about spermatogenesis. But after the two divisions, there will be 4 cells formed. There will definitely be 4 cells formed, but only one of those cells will get everything that it needs. So in a female, when you started with the one cell, it underwent division. There were 2 cells that were haploid, but the chromosomes were in duplicate form. The 2 cells divided, making 4, but only one cell will get all of the cytoplasmic structures that are needed. That will be called the egg. The other 3 were made, and sometimes those other 3 are actually called nurser or polar cells, nurser body cells or polar cells. They were essentially made just to get the one cell the chromosome number that it needed. And that one cell gets all of the mitochondria, the endoplasmic reticulum, all of the cytoplasmic inclusions that are necessary to survive as for a specified period of time. Actually only survives for a few hours, but has to be fertilized. And if it gets fertilized by a sperm, then that's the new zygote. The sperm is contributing really none of the cytoplasmic structures. The sperm is contributing the paired partner homologs, the DNA. So 50-50 DNA, 50% from the male, 50% from the female. But that's the major difference, and it is a major difference, where once one egg in a male became 4 functioning sperm, and a male made a lot of those in a 24-hour period. In a full monthly cycle here, a female will have 1 egg inside the follicle, and it will be that 1 egg that is actually going to get everything that it needs after meiosis. This follicle, the follicle where ovulation happens with luteinizing hormone, not attacking, but essentially causing the follicle to rupture and release the mature egg. This follicle then becomes the corpus luteum, which is going to start secreting the hormones necessary for the whole entire first trimester of the pregnancy, in case fertilization happens, in case implantation happens in the uterus. In case that happens, this corpus luteum is there, and which had been the old follicle, and now this follicle, this corpus luteum, aka the follicle that had nourished the maturation of the egg, will sustain the pregnancy. When we think about it, again, in this lecture we talk about 28 days, but it can range per individual. Some women, their cycles are every 20 days, some women every 45, so it depends, it changes. But we talk about these different phases. In this lecture, in this PowerPoint, there's a lot of slides that have this chart on it, but they're highlighting different areas, like this follicular phase, meaning the beginning of the follicle being targeted so that the egg will mature. FSH is pretty high here because we said it takes FSH targeting a follicle for the maturation of an egg. So this is why this is called a follicular phase. There's also a slide that will talk about just this menstrual part, not the follicular menstrual, the pre-ovulatory, meaning before the follicle releases the egg. The luteal phase, because now the follicle has become the corpus luteum, and then in case there's not a pregnancy, the premenstrual phase for the next cycle. So again, there are a lot of slides that look exactly the same on this PowerPoint, but what they're doing is highlighting the different areas. So they have made this a 28-day cycle because we said that's kind of the average. And what I want you to do is spend some time, I'm going to go over the basics, but spend some time looking at this because it really does show you how a developing follicle gets targeted by FSH, and after it's targeted, the follicle is going to be doing its work, developing the egg. The egg is developing, the mature follicle here. Then luteinizing hormone spikes about mid-cycle, in this case, for the 14th day. Around mid-cycle, luteinizing hormone is going to spike, causing that follicle to rupture and releasing the egg. And that's called ovulation. If that didn't happen, the sperm would, even if it swam all that distance through the uterus, through the fallopian tube, and the right one, the correct side, and got there, it wouldn't be able to get to the egg unless it was released. Now, this egg, let's just say this egg gets fertilized. If it gets fertilized, it takes about 6 days, and you can see that here, 15 to 21, 6 days, for this fertilized egg to get back to the uterus to implant. So implantation, fertilization could happen right here it's got to happen a few hours after ovulation. But it takes another 6 days to get back to the uterus. So the implantation's happening here later in this ovarian cycle. If implantation happens in the uterus, the tissues of the uterus will send a signal back to keep this corpus luteum there. And the corpus luteum won't involute. There will be no involution of the corpus. It will remain. It will have to. So it needs to get that signal back if pregnancy happened, because this is about when implantation's happening, late in this luteal phase. You see, luteal, meaning corpus luteum. So if that happened, this stays. If it didn't happen, if no pregnancy happens, then it involutes. The corpus luteum involutes and becomes reabsorbed, and a new follicle, because FSH is going to start to go back up. See how it's coming back up, FSH? A new follicle will get targeted for the next month. Again, I want you to just take some time and do look at these because it not only shows you FSH and LH and what they're doing during a monthly cycle, a little bit more complex than the males, right? But it's also showing you what is happening. It's also going to show you what is happening with estrogen and progesterone. Estrogen and progesterone are actually secreted by the follicles, but also by the corpus luteum. So again, this also shows you the thickness of the endometrium. If the newly developing blastocyst is getting to the uterus around late in the luteal phase here, around the 21st day, it makes sense that the endometrium that inner layer of the uterus is at its thickest. It is so nourished. It is ready. It is ready to catch that blastocyst if it's coming through. If it doesn't catch it, we said these arteries will start to constrict and these tissues start to die, and then this is what we call a menstrual flow. We're losing this and it gets thin again, the menstrual flow. The first day that menstrual flow shows is the first day of the cycle. So that's considered the first day of a 28-day average cycle. So I really do like these slides because it can show you what's happening with not only FSH and LH, not only what's happening with the follicle becoming a corpus luteum, but it's also showing you a typical estrogen and progesterone cycle. If this corpus luteum starts to involute, the estrogen and progesterone start to drop back down to typical ranges. Oral contraception, the contraceptives and other types that are hormonal contraceptives for women provide enough estrogen, it's low amounts usually, low estrogen and progesterone to make your body think you're pregnant. So instead of it dropping because you're doing the contraception, the hormonal contraception, estrogen and progesterone stay high, just like they would in a pregnancy. If pregnancy happens here, remember, the endometrium is going to stay nourished and the corpus luteum is going to keep estrogen and progesterone high. It has to sustain the pregnancy. What we are seeing in these are when no pregnancy occurs and the menstrual cycle starts again. So again, these are great little slides to sort of, spend a few minutes with and make sure you understand what is actually happening. So good. The female sexual response, just like in the male, I'm not going to talk about it too much, sort of a different class, but certainly if we take a look at this female in this position here, you can see the vaginal opening here and the fornix of the vagina, but you can see the cervix of the uterus. This is unstimulated. Some women's uteruses tilt back even in an unstimulated. I've heard people say that they've had practitioners tell them that that may end up causing some issues with fertility. That is not true. Not true. So just so you know that is not true. And a sexual response, the uterus is always tilted back. So it's tilted back then, and that's not, so if it's always tilted back, it's not going to do it. It has nothing to do with fertility. So orgasm, we understand, these are rhythmic contractions. I think people know. So during that time, urinary and anal sphincters contract. So during the orgasm, and resolution can happen. Usually women with major differences that multiple orgasms can happen. When we think about, I want to go back to the endometrium for a minute here. This endometrial lining that is going to be nourished, shed at the beginning of the cycle, and then rebuilt back up in case fertilization happens late in the post-luteal phase, around the 21st day, and then shed again. Sometimes this endometrial tissue can actually migrate out of the uterus. If that happens, I'm going to go back to the uterus a second. If this endometrial tissue does migrate out of the uterus, sometimes it can migrate and get stuck in the fallopian tube. Sometimes it can migrate into the pelvic cavity, abdominal cavity. It can even migrate to other areas in the body. But this endometrial tissue is very specialized, and no matter where it is, it's going to be affected by the monthly cyclic hormones. When the endometrial tissue is not in the inner uterus, this can lead to a condition called endometriosis. So endometriosis is a disorder where the endometrial tissue has migrated from the uterus into another area. And it can be incredibly, painful for women. and almost debilitating for others. And it may lead to some issues with fertility, because if that tissue has got lodged in the fallopian tubes, then it could block those tubes, so sperm couldn't get through, and or the fertilized blastocyst couldn't come back through. So it may lead to even a higher chance of ectopic pregnancies. An ectopic pregnancy is a pregnancy outside of the uterus. So if that is happening, oftentimes it's in the fallopian tube. That is a life-threatening event for a female. Before modern medicine, surgical techniques, emergency surgical techniques to remove the tube, this was a death sentence for women. But now, now if women get immediate care with this, if they have a tubal pregnancy, they call it a tubal pregnancy or an ectopic pregnancy, they get immediate care and their lives can be saved. They remove the tube and the newly developing blastocyst. Has to be, or otherwise this would rupture and it would lead to internal bleeding that would equal death. So again, I'm not saying all endometriosis leads to this. It does not. Many women have mild forms of endometriosis that do nothing to them as far as fertility goes. Some women get here when they hear, because they don't have the medical background, but they may hear a practitioner say, well, you're exhibiting some signs of endometriosis, and this can lead to fertility challenges or issues. And what that patient hears is that they can't get pregnant. So they stop birth control and then they're pregnant in the next month or two. So, I've known that to happen so many times. So it's very important how health professionals actually discuss issues, these types of issues, because endometriosis is fairly common. Luckily, the very severe forms of endometriosis are pretty rare, but some women do have incredibly severe endometriosis, enough so that surgical intervention is required, where they will go in the pelvic area and see the endometrial tissue outside of the reproductive little arena here. And sometimes we'll have to do, remove tissues and really try to help with that. So some are rare, are pretty serious, but not usually. Okay, so I'm going to go back to where we were, and thinking about pregnancy and childbirth. So pregnancy is typically, when we think about the birth, is predicted 280 days from the first day of the last menstrual cycle, the last menstrual period, the first day of that. But actually we know that that first day, ovulation didn't even happen until about the 14th day, did it? And then there was a few hour window there that that fertilization occurred, and then late, around the 21st day, implantation happened. So really gestation lasts about 266 days, but it's predicted from the first day of the last menstrual period. It's separated in 3-month intervals that we call trimesters. And again, I have given you all this type of, these terms to know that a zygote is the first cell that's formed. Once that cell starts undergoing mitosis, which is a cell division for growth, regeneration, repair, development, the blastocyst is the first 2 weeks. It's called a blastocyst. Around the 6th day in implants, from around 2, I guess you've already used tube, so 3 to 8 weeks, an embryo, 9 weeks to birth a fetus, and then a newborn, a neonate, up to 6 weeks. So, again, I want you to know that there are different hormones that we think about for pregnancy. The major hormone you hear about is called HCG, human chorionic gonadotropin. This is the first hormone detectable for a pregnancy, and so all of the pregnancy tests, whether it is in a pathology lab or whether it is in a drugstore, the little tests are based on this hormone, HCG. It is the first one that is going to rise to significant levels with a pregnancy, and then it'll start to come back down. But then we also look at other hormones. Estrogens are 30 times normal before the birth of a fetus. So this has increased greatly, hasn't it? The corpus luteum is that source for the first 12 weeks, which is that first trimester. I told you that follicle, if you become pregnant, becomes this corpus luteum that has to remain for the first entire 12 weeks. After that, the placenta takes over. But if there's a female that has lost several pregnancies before that first 12 weeks is up, oftentimes it can be absolutely diagnosed back to the levels of hormones not being sufficient from the corpus luteum, not sustaining the pregnancy. It's not uncommon for women to lose pregnancy in the first trimester. So again, those numbers, the estimate of those numbers are they're kind of significant. So some people decide not to even talk about or that they're pregnant until they're after 12 weeks, because then the placenta has taken over and the incidence of a sustained pregnancy go up after that particular time. Again, all before this is going to cause lots of changes. These estrogens going to change the uterus, the mammary ducts, and the breast tissue. Progesterone is also secreted by both the placenta and the corpus luteum. This is what's suppressing FSH and LH, because if you are pregnant this month, you do not need to have an egg produced next month. You don't. And most of the time, that works. So, once you are pregnant, you're not going to be producing eggs during the pregnancy. On occasion, rarely, but on occasion, women will have another egg the next month, and they may even get pregnant and have twins of different gestational ages. That is really rare, but that has happened, and the reason that has happened is because this didn't quite do what it was supposed to do. But progesterone will suppress the secretion of FSH and LH. Again, when you are taking contraception, hormonal contraception, it is low-dose estrogen and progesterone, which makes your body think it's pregnant. So it suppresses the FSH and LH, and you do not need another egg forming. So it's preventing all of these things that we're actually seeing here. There are other hormones as well that are involved. It is not just HCG and estrogen and progesterone and HCS. It's not just these. There are others as well. The thyroid gland is going to increase and increase its production of TSH, of thyroid stimulant, of T3 and T4 by as much as 50%. So calcium is going to be needed for this newly developing embryo and fetus. So all of these things are increasing the mother's blood volume. And this is why, pregnancy is, good prenatal care is very, very vital, because this does essentially put a burden on the mother's system. It's a very natural thing, but it potentially can. So if women have already pre-existing conditions like hypertension, then all of a sudden the blood volume's increasing because of the hormones of pregnancy. This could exacerbate some pre-existing conditions in women, but it is a natural situation, and usually, usually things go right. When they go wrong, it's not a good place to be, but usually everything's going right. So again, ovulation occurs, but it is days later that implantation occurs, and you can see how quickly the hormone levels relative to each other are going up, HCG being the first detectable one, and this is why those tests are based on HCG being present or not. Most of them are qualitative, so they're just a positive or negative. They're not telling the amounts of HCG, it's just yes or no. You can't be a little bit pregnant though, you're either pregnant or you're not. But if something starts to go wrong and early on, they can do quantitative as well, where they actually get the actual amounts of these different hormones to see where they are, if they think something might not be quite typical or following the, how we typically see it happen. So they can do quantitative as well. And in a lab, they can do that. So adjustments of pregnancy, there's a ton of adjustments. As you can see, they've removed the uterus, like the uterus has been cut here. It's now thinned out because this muscular sac is really, expanded. But obviously there's a lot of things going on. Some women, especially if they have short torsos, can feel very breathless during that latter trimester, because their diaphragm, that dome-shaped muscle here, and the lower part of the ribs, this dome-shaped muscle separating the thorax from the abdominal cavity, can't contract as usual. So the lungs can't change shape, and you all know how that would affect your respirations. So some women can feel that. Some women feel GI issues like either constipation and or diarrhea. Some women have very much, sometimes even incontinence issues with the bladder because of the fetus pressing on the bladder later in the last trimester of the pregnancy. Nausea is fairly common in the first few months, just in the first few months. The cause is unknown. It's certainly thought to be hormonal based. And if there is severe nausea, it usually goes away after a few weeks. But if there's severe nausea, this is where there's vomiting happening, and it's lasting more than just mornings or evenings. It's happening all the time. That is actually referred to as hyperemesis gravidarum. Hyperemesis gravidarum is what that's called, and that can be debilitating, and that puts the mother and the fetus at higher risk. So it may require some IV feeding, some very special care and monitoring if the mother is not being able to take in the nutrients that she needs. But typically this is fairly common, and it's going to resolve and it's going to go away shortly after the first trimester. So as I said, some people have constipation and heartburn. A good weight gain is about 25 pounds. They want to see, of course, it would depend on the health of the mother going in. Some might need to gain a little more, some may not need to gain as much. We understand that nutrition is vital, so supplementing with extra vitamins, especially that folic acid, can prevent some neurological disorders. We saw that when we looked at the nervous system. So spina bifida is one example of that, and anencephaly means being born without a brain, which obviously only survives for a couple of minutes out of utero. So very much high demand for protein, iron, calcium, all of these things in that third semester. And there are a lot of accommodations that are actually happening. You can look through those. I talked about some of these. As far as parturition, this is the process of giving birth. It requires that uterus to contract. You might think you could just push a fetus out, but that would be impossible. That uterus is an amazing muscular sac. So oxytocin targets that uterus for contractions, and then the mother also helping with abdominal muscles and pushing during that labor stage. The labor stage is the pushing stage. Braxton Hicks are called false contractions, false labor. Some women actually go to the hospitals because they think they're in labor. They're having these contractions. They're typically painless, or painless compared to actual labor. So, it's really the uterus. It's thought that the uterus is actually just practicing, getting ready for this. And some women have these and some women don't. I think they're more typical in second, third, subsequent pregnancies, and not so much the first one, but some women have them the first one as well. Okay, so the fetus itself controls when a mother goes into labor. The fetus is going to be secreting cortisol because the fetus is actually being stressed later in pregnancy. The fetus is running out of amniotic fluid, running out of space, is cooked, is ready to be born. And so with that, the fetus is secreting that, and it's going to actually start the oxytocin cycles here. Labor is divided into different sections. We know that the pain of labor is actually from the myometrium, the muscle of the uterus contracting, and a lack of blood supply to it during those contractions, which is causing the pain. So that's what we know is happening. So breathing, this is why, holding your breath during contractions is not a good idea. Deep breathing and breathing regular, maybe even increasing a little bit, is actually a good way to manage that. Staying calm, and as I said, not holding your breath, which people tend to do if they're in pain, or hyperventilating, which would not be good either, or screaming. All of those things would really enhance pain instead of actually helping. And again, it is in cycles, so that when there's not a contraction, there really is not pain happening. So there are breaks between the contractions. Of course, they get closer together and later part of delivery, so there's not much breaks. But anyway, so in the early stages, the cervix is actually needing to open up to 10 centimeters. So OBGYN nurses and doctors are very good at, because they're doing vaginal exams with their fingers, and they're measuring how open the cervix is. And so really, you cannot push, this is early, until that cervix gets to 10 centimeters. If a woman, and again, when you're in pain, sometimes you're kind of bearing down. That's a terrible thing to do, because you really don't want to push if the cervix isn't at 10, because this head could pinch off part of the cervix and actually cause these tissues to start to swell, and that's going to block the birth canal and or could damage the cervical tissue. So your body kind of tells you during this time that, like, when to push. It's like it becomes a very obvious kind of thing. Now, if somebody's had an epidural, then they can't feel any of this, so they're really having to rely on their physician or their nurse assistant or their midwife or whoever's helping to tell them like where they are in the stages of it. In late dilation, when you've gotten to 10, this is called labor. Now that's actually called labor, the pushing part. The proper presentation is head first, face down. Anything that's not head first, face down, coming through the birth canal is called breech. So anything that's not that is actually called breech. When the amniotic sac breaks, this amniotic fluid this is what people call breaking the waters. So this fetus is actually in an amniotic sac, and when that sac does break, this is again what we call the waters breaking, and that has to happen as well. You can see the placenta is in a perfect location here. It's behind the fetus. Sometimes that's not the case. The fetus is going to develop where the implantation happened. And if the implantation happened too close to the cervix, it could be blocking. Look at this placenta. It could be blocking the cervix. If that's the case, that is called placenta previa. And that, again, long before modern medicine, that was a death sentence to the mother and the fetus, because the fetus would have no way out, and hemorrhaging would have taken the life of the mother, and then the lack of blood supply would have also taken the fetus. So placenta previa, we know where the placenta is from an early ultrasounds during prenatal care. They look to see where the placenta is, and as long as it's here or not blocking the cervix, it's fine. But if it's blocking the cervix, this is going to be a scheduled cesarean section delivery, because the fetus would not be able to leave if it's blocking. Sometimes the placenta breaks from the uterus prior to delivery. That's called placenta abruptia. And again, that is going to be indicated by massive bleeding. And this is an emergency situation, an emergency delivery. So again, usually things go right, but sometimes things don't. And so prenatal care, good prenatal care and diagnosing and screening is important for those types of things. So again, the labor part of labor is when the fetus is moving through the birth canal, and there are different stages of that. So again, head first, face down. If it's face up, if it's butt first, feet first, hand first, whatever, then those are considered breech. And there are a lot of of physicians who won't deliver breech fetuses, so they will go ahead and schedule C-sections. Breech deliveries do have, especially if somebody doesn't know, hasn't handled a lot of those, do have higher risk to both the mother and the fetus. So now, we live in a world of litigation, and so now a lot of practitioners won't even risk it. They will do C-sections. Cesarean sections are major surgery for the mother and carry all the risk of major surgery for the mother. And we also know they carry risk for the fetus as well. So, that's not done or not should not be done unless there's actually a real reason for cesarean section. Most labor, which is the hardest part, is the pushing, and the delivery. Most only last around 30 minutes, but some a lot longer. Some even shorter than that, But anyway, the Valsalva maneuver, where the mother takes a deep breath, expanding her thoracic cavity, holding that breath, and bearing down on the abdominal area, can help to push. But again, that should only happen after the cervix has gotten to 10 centimeters and, you're pushing at that part. The placenta being delivered is also the next step, and it's really important that the placenta not only be delivered but be examined, and examined carefully, that no pieces of it were left behind in the uterus. You can see how the uterus is folding up here after the expelling the fetus. And what's amazing is that, especially if a woman is breastfeeding, because the oxytocin will continue. Oxytocin needs to continue if a woman's breastfeeding. That oxytocin will get this uterus back to its pre-pregnancy shape within a few weeks. Not that it's recommended you get pregnant that quickly afterwards, but I'm saying it will. The uterus will be back to its pre-pregnancy shape. So I think that, I'm trying to think if I've missed anything here. I don't think I did, other than the term dystocia. The word dystocia means difficult labor. And sometimes it's dystocia because maybe the presentation of the head is not where it should be. The fetus is not where it should be. Sometimes it's shoulder dystocia because the shoulders end up being bigger than the head, which is not that uncommon. But anyway, typically when the head is delivered, the next contraction, you wait, and the next contraction that is happening, the shoulders are delivered and the fetus is out. So, hope you'll get to see, if you haven't already seen that, I hope you'll get to do that someday, see that. It's amazing experience. So, so when we think about, again, post-delivery, when we think about the first 6 weeks after delivery, we know things are going back kind of to normal. Vaginal discharge is called lochia. This is actually a whitish kind of discharge that can be a lot of it, but that's actually normal, and new mothers need to be told about that. If the mother is breastfeeding, then lactation is going to occur because there will be cyclic productions of prolactin and oxytocin. Prolactin for the production of milk, oxytocin for the ejection of milk, or what is called the letdown response. The first milk in the beginning is actually a goldeny looking secretion, so it's called colostrum. It is full of glucose. It is also full of mother's IgA antibodies, which are incredibly protective because they line the neonate's GI tract, the entire GI tract. So even if a mother doesn't want to breastfeed, maybe just doing the first few days is so important because this colostrum is so rich in the mother's own antibodies that can protect that baby for weeks. Not forever, but for weeks. And that would be a great thing. Breast milk. Breast milk is, there's some comparisons in your textbook that show you comparisons of mother's milk versus formulas and versus like cow's milk and other things. So you can see some comparisons. As long as the mother is healthy and there's not been any reason why the mother can't breastfeed, there are sometimes reasons why a mother can't breastfeed. Breast milk is always the the best solution, but only if the mother is able and wanting and willing. Otherwise, there are plenty of formulas that are absolutely do the job, you know. Now, some women hear that if they're breastfeeding, they can't get pregnant. That would not be a good form of birth control to use. That is not. So, because there's a significant number of women who can become pregnant while they're breastfeeding. So, anyway, that should probably long ago, before contraceptions were readily available for most people. Not everyone still, but most people, then this was kind of what was used to prevent, you know, subsequent pregnancies. This shows the peaking of prolactin with the production of milk with each breastfeeding, and milk ejection, we said, is going to happen because of oxytocin. That's that letdown response. And again, an infant does not have to be suckling for that to happen. You can just think about it, and the woman's thought process can cause that letdown response to happen. Again, here's a table where you're comparing, in your textbook, comparing some of this, and that's just FYI. Women usually are going to produce as much as their infant is demanding. And it's important that we understand that neonates cannot control their blood glucose levels. So it should be a regular type of feeding, and breast milk is actually digested much quicker than other types of formula. So it's usually more often that they're doing it. They're actually breastfeeding than if they're doing formula. But you have to sometimes wake babies up if you think it's too much time is going in between, because again, they can't control their glucose homeostasis. So they need regular routine feedings early on. That would be an important thing to do. It also keeps the milk in. I think the only other thing I haven't told you about with infants is something called meconium. Meconium is this in a fetus, inside of a developing fetus. You know, a fetus is actually, before the amniotic sac breaks and the water breaks, a fetus is in a relatively sterile environment. So they're swallowing amniotic fluid, you know, they're urinating and they're swallowing amniotic fluid. It's a sterile environment. But what they're not doing is having any sort of bowel activity. Bowel activity is usually stimulated after birth. But inside of the bowels is this sterile, it's sterile. It is not feces. I know that sometimes even in text it's written that way, and sometimes health professionals will say to a new parents that this was feces, that the baby swallowed feces or may have inhaled some feces. It's not feces, it's meconium. It is this sticky, dark, greeny, black kind of substance that is lining the intestines of a fetus. It's sterile, but it's lining so that those cells are developing. The inner lining of the intestines are developing. After birth, a bowel movement that happens in a neonate happens usually due to feeding. The whole feeding process causes the bowels to release, and you see this meconium that is passed. It's sticky, it's greeny, dark color substance. Some fetuses during delivery, especially if it's a difficult delivery, when the water breaks, the amniotic fluid should be clear and colorless. But if it has any tinge of green, or any kind of grainy tinge, or any kind of tinge, dark tinge, it means that the fetus has expelled some of that meconium prior to delivery. If that has happened, that fetus is at higher risk for respiratory distress, because while the fetus is inside and not being delivered yet, that meconium is kind of sticky. And if they got any of that, if they inhaled any of it or aspirated any of that, then it puts their lungs at higher risk after delivery. So again, meconium staining of the amniotic fluid, which should be noted, And it would mean that this fetus is this neonate now, because it's being born, this neonate is going to be watched carefully for the first few days, just to make sure there's no respiratory compromise. And again, that's called meconium staining. You should not tell new parents that that's feces. It isn't. It is the secretions that are natural and normal lining these tissues and these areas. So anyway, all right, so I think that was the last thing I was going to talk to you about, and this ends our chapter on the female reproductive system and also gestation. So I hope you enjoyed that. We have a very short chapter to follow and end up AMP2, and you guys are almost done. Congratulations.